Hi, I'm Lee Fleisher. I'm the DRIPS professor and chair of anesthesiology at the University of Pennsylvania. I also teach a course on the science of value-based healthcare to the medical students, and I'm very involved in managed care contracting for the health system. And the question that Justin Clapp, an anthropologist in my department and collaborator, and I started to address is, does shared decision-making exist? And could this be utilized to actually reduce low-value care and or no-value care for some patients as they made decisions about procedures? This really grew out of a perspective of what is informed consent and could we actually measure the quality of informed consent. One of the measures being actually proposed to NQF is a checklist of what's in the piece of paper that patients sign. So, working with our surgical collaborators, in particular Steve Raper, we identified a series of elective procedures. Justin actually sat in the room while the discussion was occurring, watched the discussion, listened to the discussion, coded the discussion, as well as interviewed both the surgeons and the patients after the conclusion of the consultation about this elective procedure. The key findings really was that the signing of the paper was not really informed consent. But what was most interesting with regard to shared decision-making is that the process of the decision from the patient's perspective really started prior to them entering the room. That in fact, it started when they talked to their friends, their family, their primary physician who referred them to the surgeon. That what happens in the surgeon's mind is they know about the condition, they frequently read the chart, they may have a probability of risk versus benefit, and then a second discussion, so to speak, occurs with the patient, and finally, they may or may not sign the informed consent. Now, the relevance to healthcare innovation is if we want to actually drive value from a patient's perspective, that if we want to make sure that the patients get the care they receive, that in our minds, just using the shared decision-making model today may not work. We may actually have to go earlier in the process. We may have to actually influence how the surgeons present their recommendations in order to change and make sure that the patient's preferences and the patient's desired outcome is better achieved. In fact, there's a lot of work around how best to do that presentation, including, instead of just probabilities of outcome, best worst case scenarios. So my hope and our hope over the next several years of using ethnography to study the question will lead to some novel interventions, some innovation in presenting procedures so that we really drive outstanding outcomes at the lowest cost and make sure low-value procedures are not, or particularly no-value procedures, are not performed.